Hello, my name is Sarah Maines, and I'm the Liver Cancers Program Director at Global Liver Institute, the world's largest liver patient organization. Thank you so much for joining us today. We are talking all things the management of hepatic encephalopathy, ascites, and portal hypertension. We are really glad to have you here today. Global Liver Institute brings together more than 200 organizations across our councils, campaigns, and events to continue to advance liver health as public health to both prevent liver disease and scale optimal approaches to improving the lives of individuals and families who are impacted by all liver diseases and liver cancers. Today, as we dive into ascites, portal hypertension, and hepatic encephalopathy, three hepatic issues that impact individuals dealing with liver conditions. It is vital for patients and caregivers to be well informed about these conditions, as it empowers us to effectively manage symptoms and adhere to correct treatment plans. Additionally, we've noticed a gap in healthcare providers' understanding of hepatic encephalopathy, sometimes resulting in patients being misdiagnosed with various psychiatric disorders. And to shed light on these matters and advocate for better awareness, we have organized today a two-part discussion featuring insights from 4 leading health experts, along with a patient advocate. For our first part of conversation today, we are joined by Dr. Christopher Rose, professor and director of the Hepatoneural Laboratory at the University of Montreal, also joined by Dr. Elliot Tapper, professor and director of the Michigan Cirrhosis Program at the University of Michigan Health. Thank you, doctors, for both being here today. Welcome.
Hello, everyone, and welcome to this session on hepatic encephalopathy. I would like to thank Sarah and GLI for allowing myself and my colleague, Dr. Tapper, to discuss a bit about what hepatic encephalopathy is and probably a little bit about the management of patients and so forth. So I'm Christopher Rose from the University of Montreal in Canada. I direct the Hepatoneural Laboratory, and I've been working in this field for almost 30 years, so it's been a great honor to be able to discuss and present what we know to date. So hepatic encephalopathy really is, the question arises is when the liver fails, why does the brain fail? And by definition, it's a neurological complication of liver disease, which manifests as a wide spectrum of neurological abnormalities ranging from subclinical alterations to coma. And it's important to note that this is after exclusion of other known brain diseases. A few facts that you should be aware of about hepatic encephalopathy. It's a very frequent complication. The incidence of HE is 11.6 per 100 person years, which has increased over 40% over the last 5 years, coming from 2014. It defines decompensation. That's also an important mark for hepatic encephalopathy. It impacts on hospitalizations and readmissions, where we saw an increase by about 30% on HE-related hospitalizations over a span of 5 years also. And has impact on mortality with a twofold increased risk of 1-year mortality compared to cirrhotic patients who do not have hepatic encephalopathy. And of course, the financial burden has gone up quite dramatically with a 46% increase over the span of 5 years also. I think it's important to note that encephalopathy, as the word describes, just means that there's something wrong with the brain. It doesn't actually have a specific syndrome or a symptom as far as hepatic encephalopathy. Just means there's like a kind of like a storm going on, and there's a lot of different symptoms that could be arising due to this liver disease. Back in the day, the West Haven criteria was established to help grade the degrees of hepatic encephalopathy, and it started off with a grading from 0 to 4 and had different evaluations on the level of consciousness, neuropsychiatric symptoms, and neurological symptoms. And you can see through these little definitions in each of these grades that there's quite a subjectivity that's there and a lot of overlap. So as a society, as a hepatic encephalopathy society, move forward, we decided to actually try and simplify things in having overt and covert. Overt being symptoms that are clinically relevant and easy to diagnose, whereas covert HE are sort of symptoms that are not clinically easily to diagnose and usually detected with neuropsych tests. And we do know that there's a continuum that patients who do have covert HE, who are diagnosed with covert HE, have a risk of developing overt HE in the near future. And once a patient does arise or come to the hospital for an admission with hepatic encephalopathy, we call it an episode or an episodic HE. And these patients do return twice within the same, within 6 months. And we call this recurrent hepatic encephalopathy. Now, the pathogenesis of hepatic encephalopathy is quite complex. And I think it's important to note that it is not a neurological disease. This is something that's arising from a systemic circulating problem, in this case, liver disease. So there's a lot of systemic factors that can arise and have an impact on the brain. As we see to the right, hyperammonemia, blood ammonia plays a major role in the pathogenesis of hepatic encephalopathy. And there's also a lot of other factors that can be induced or increased during liver disease. And of course, these have an impact on the blood-brain barrier. And once they get into the brain, we know there's a lot of complexities that could be arising, which can be resulting in encephalopathy. But I think it's also important to know that ammonia by itself is toxic, but also if it has some kind of partnership with other kind of pathogenic factors, that it can increase its toxicity. So depending on the environment of ammonia at that state, it can actually reflect in its severity and neurotoxicity. So what is ammonia? I mean, ammonia is something we produce every day when we have a meal by protein digestion, amino acid deamination, mostly arising from gram-negative anaerobic bacteria. And of course, the hydrolysis of urea, which actually produces ammonia when it's breaking down urea. Everything from the gut is absorbed and enters the liver, and that's where we have the urea cycle, which is the primarily housing of enzymes that is only formed in the liver. And this regulates the ammonia that's produced from our gut. And after it leaves the liver, we have very low levels of ammonia. But once the liver does not work anymore, or is impaired, or is severely cirrhotic, the elimination obviously decreases. And there's a lot of evidence to show that even the ammonia production may be increasing due to the microbiota changes that we are aware of at this point. So because elimination goes down, blood ammonia levels increase, which can easily get into the brain. And we know ammonia is toxic, neurotoxic, of course, and becomes a major factor in hepatic encephalopathy. So what really is ammonia? It's actually a weak base, and it's also a weak acid, so it can accept a proton. It can also donate a proton. But at physiological pH, only 2% of ammonia is as a gas, and 98% is as a ion part of ammonia. And the ionic part of ammonia, which makes it very special and actually quite toxic, is very similar to potassium. So it's a similar ionic radius, has similar diffusion coefficient. So everywhere that potassium goes, either through transporters or channels, the ionic part of ammonia can follow. Here's just a sort of a diagram showing that there's many different channels that are associated with potassium transport. And there's actually ammonia transport, which was recently characterized, which has not really advanced since then. So if you're actually following the story, since potassium can get everywhere in the body, so can ammonia. So ammonia can get throughout all tissues and organs, and we actually think it may have an impingement on other organs. I think definitely the brain is probably the first victim, but it is not to say that ammonia can also be affecting other organs. But already another direct effect of ammonia is that the fluctuation of ammonia going across cell membranes can actually have an impact on the pH. Here's a study I did way back the day in Germany, that if you apply pH to cells, we see a change, an increase in pH. And if you remove the ammonia from the cells, you see a decrease in pH. And if you take the same kind of weak base, weak acid, such as trimethylamine, which is similar pKa as ammonia, we don't see this great expansion of increase in pH and a decrease in pH. So this fluctuation of ammonia causing an acidification and alkalization is actually something that can be detrimental to the cell and its metabolism. So aside the pH, the fact that the ionic component of ammonia is very similar to potassium, we believe it has an impact on the membrane potential. And ammonia is actually involved in a number of different biochemical reactions. And so we need ammonia in our body. We don't want ammonia to be at zero. So it's necessary for physiological reactions, either generating ammonia or using ammonia. I think this is actually an important aspect which has come around within the last little while. Hepatic encephalopathy is a metabolic disorder. By definition, it means that if you correct a problem, everything should resolve. So following the insertion of a new liver during liver transplantation, the brain should be normal. In the beginning, this liver transplantation was very invasive and very high risk. And of course, survival was an important endpoint. But actually, after knowing that there are advancements in surgery are doing really well, we started to look a little further into detail about these patients and what they're doing after transplantation. And if you look a bit closer, we still see about 15 to 45% of these patients still have persisting neurological complications, even though they have a new liver. I'd like to tip my hat to Dominic Tabou and Nicolas Weiss from Paris, who actually elegantly describes all these neurological complications post-transplant. It's not just a delirium acute setting after transplant. These are actually cognitive complications that arise after 6 months or persist after 6 months. So if you take the studies that are showing patients with poor neurological outcome and you look into the medical files of these patients, you'll see that a lot of these patients had repeated episodes of overt HG. So a lot of history of hepatic encephalopathy leading up to transplantation. And our colleague, Dr. Bajaj from the US, has elegantly published and has actually told us many times that patients who receive multiple episodes become refractory to treatment and very difficult to treat. It's important to note that someone who's diagnosed with covert HG has a 10 to 30% risk of developing their first episode within 1 year. And once you have that first episode, within the next year, you have a 46% risk of developing the second episode. And to the third, it decreases within 6 months, but increases the risk of 55%. So there's kind of something going on with the brain with these repeated episodes that the brain is becoming more susceptible to these episodes. And the analogy I like to use is sort of in sports with concussions, that once you have one concussion, you're susceptible to have secondary concussion and tertiary concussions. So in our lab, we decided to figure out what is the impact of all these multiple episodes over HG. So in our laboratory here in Montreal, we use an animal model, the bile duct ligated model, which you ligate the bile duct and all the bile stays within the liver and then it becomes toxic and the liver becomes fibrotic. And it's characterized, this model, with an increase in blood ammonia. There's ascites that develop within the abdomen, and there's jaundice. Then if you put these animals in an array of different behavioral tests, we can see that there's brain edema, there's impaired memory, there's learning deficits, anxiety, and impaired motor activity. So in the end, this is an animal model of covert HG. If you look at the animal per se, you don't see anything obvious, but if you put them through all these array of tests, you'll see that they're actually not normal. So Farzaneh Tamalu from my lab decided to take on this task. And so our BDL animals run for about 5 to 6 weeks. So she decided to inject ammonia at just before week 3. And when you inject a certain ammonia, in this case, it's a reversible dose, within 20 to 30 minutes, these animals fall, they lose their ready reflex. So you put the animal on their side and they don't right up. Animals do not like to be put on their side. So in this case, if we put them on the side, the animal stays. And then within 20 to 30 minutes, the animal rights up and he behaves normally and starts running around this cage. So we defined that as an episode of overt HG. And then what she did is that 4 days later, she injected another episode. She did 4 episodes of overt HG using ammonia. And of course, we controlled this with saline. And at the end, after about a week after her last episode, we reevaluated these animals in different behavioral assessments to see whether they actually are the same impaired or whether their impairment exacerbated. Interesting enough, to get the same phenotype, FARS injected less ammonia to get the same reaction. So this is important. So it's really showing that the ammonia becomes more sensitive to the ammonia toxicity. And it takes less ammonia to induce the same kind of overt episode. This is just a respect to FARS for all the work she did. So within the brain, she did a lot of immunohistochemistry, and she looked at 3 different regions: the frontal cortex, the hippocampus, and the cerebellum. And she looked at a lot of different neuronal markers and astrocytic markers. And then as a summary, looking at these 3 regions, she found that the hippocampus, after the animals that had all these multiple episodes, had severe cell injury and actually cell loss. So there was a neuronal cell loss in the animals that received these episodes compared to the animals that did not receive the episodes. And then actually when she took these animals and put them in all these behavioral tests that we do, we saw that the ammonia-induced episodes, multiple episodes, exacerbated the long-term memory as well as the short-term memory. So again, showing that the impact of all these episodes leads to something more permanent in the brain, as in neural cell loss, and of course has an impact on the behavior. Whether the neural cell loss is what's underlying this in the exacerbated long-term memory is not actually sure, but that's what we speculate. So interesting enough, we also decided at one point to see what is the impact of having hepatic encephalopathy going into liver transplantation. Now, liver transplantation, as I mentioned before, is very invasive, and there's a lot of different perioperative conditions that can arise. We have duration of the surgery, which could be 2 to 8 hours. There's a lot of blood loss. There's hypotension, anesthesia, and of course, immunosuppression, which we take after we receive this new liver. So our hypothesis is that an HE brain can actually be a frail brain. So in that case, a compromised frail brain, HE brain, becomes predisposed to what would normally be an innocuous perioperative insult, resulting in cell injury and cell death. So what we did is we took these BDL animals again, and we compared them to normal rats. And so these BDL rats, as I mentioned before, have covert HE, and we induced hypotension to these two groups. And we found that it led to a decrease in neuronal cell count in 3 different regions of the brain. So again, just a hypotensive insult to an animal which has covert HE led to neuronal cell loss. So we wonder, can we actually help these animals? So what we did is we treated these animals with a treatment called ornithine phenylacetate, which has just finished its phase 2B study. I won't get into the details of how it works, but it's primarily an ammonia-lowering strategy, which is targeting the muscle within these animals and patients. And so when we treated these animals with OP, we saw that lowered ammonia, which we see on top. And then when we evaluated their neurobehavioral assessments, we see that also protected against any kind of subclinical or covert HE. And then with those animals, we again induced the same protocol of hypotension to these animals. And we saw that the animals that were BDL with no HE, without covert HE, because we protected with OP, we see that they were protected against this neuronal cell induced injury. So this actually again shows you that we can actually do something to these animals and possibly to these patients. I think we just recently wrote this review talking about the brain and liver disease, how it's kind of a bumpy road. And if you look on the top left, here's called minimal HE, but the progression of liver disease can lead to covert HE and possibly episodes of overt HE. And that per se can have a detrimental effect on the integrity of the brain. Then after that, if that patient is transplanted, they're going to go through a lot of different intraoperative factors, which of course are these insults, which also can take its toll on the brain. Once the brain comes out of that kind of procedure, after transplant, of course, it's going to be taking on immunosuppression for the rest of its life, and there may be some opportunistic infections. So in the end, we see that this brain injury that we see at the end may be due to something that happened at the beginning or something along the way. And so it's actually almost kind of worrisome about the route that this brain takes during the progression of liver disease. So sort of as a summary, I mean, covert HE, attention deficits, memory impairment, increased reaction time, sensory abnormalities, difficulty in concentrating. And of course, all these subclinical impairments have an effect on our daily lives. We don't work every day. We're taking a lot of days off of work. It's associated with an increasing number of car accidents. We're sleeping poorly, social economic status, and loss of independence. So covert by itself can definitely affect the living of these patients. And then we have overt HE, which is, again, clinically obvious symptoms, gross disorientation, severe confusion, asterixis, stupor, and even coma. So we know that there's a lot of patients who do have covert HE, which are not totally always diagnosed, and that can lead to an increased risk of having overt HE in the near future. And once you have an episode of overt HE, obviously it increases the risk of mortality within the near future. And then if you are transplanted, having this sort of history of overt HE can lead to an increased risk of non-resolved neurological complications after transplant. And of course, that could lead to a poor quality of life. So again, it sounds like a very sad story, but I think it's important that we try and identify the patients at the beginning and try and catch these patients and try and do some kind of preventative work on them to protect their brain as they progress through liver disease, and if ever they are transplanted, to have the best outcome neurologically following transplant. So I think I've sort of left the screen for my colleague Elliot Tapper, who's a superb clinician, who's going to talk about about the management of these patients. So I pass it over to you, Elliot, and the stage is yours.
Thank you, Dr. Rose, for setting the stage for a discussion where we're going to go deeper into the clinical management of hepatic encephalopathy to empower people with the tools that we can use to prevent the development of HE and also forestall progression of HE to that brain injury that you heard so much about. By way of reminder, I'm Elliot Tapper at the University of Michigan, and it is a privilege to be here with you today. So just to review, we're talking about a clinical spectrum of neurocognitive impairments that ranges from the covert encephalopathy, which is deficits in quality of life and executive function, to overt encephalopathy. And this branching, it lends itself to a paradigm where we're really thinking about covert HE in people who are out and about in the outpatient setting, and overt HE is often the stuff of hospital-based management, because when you're lethargic, acting inappropriately, somnolent, or of course comatose, you're going to scare those around you, and that will prompt emergent evaluation. So we're going to break up our discussion about management along the lines of addressing these two different presentations of the same underlying physiology that you heard about earlier. So covert encephalopathy, as you know, it can cause changes in your cognition, but also can manifest as depression, instability, falls, car accidents. And because people with covert HE become afraid of taking steps outside, they're aware of their own deficits, but they become withdrawn. They therefore can actually exert a bit of a drag on their caregivers, becoming less independent. And people who love patients with hepatic encephalopathy, their health and their well-being also suffers. These are all of the negative externalities associated with covert HE. And overt HE, as you've heard, creates repeated progressive injury to the brain, which is manifest almost like a revolving door of repeated hospitalization, which is, of course, costly, but not only to the healthcare system. It creates a kind of domino effect whereby each additional hospitalization experienced by a patient with hepatic encephalopathy increases their risk of dying. So we have a lot to do, because there's a lot of horrible outcomes that we would like to prevent. The first and most important opportunity is to prevent the development of overt encephalopathy through early detection. There are a number of tools that are available. I will name some of them, and then I'm going to go deep on how I would apply them at the bedside. One of them is an app you can download to your phone called the Encephalap Stroop. Another one is called the Animal Naming Test, which I'll describe, and recently developed by colleagues of ours in the United Kingdom. The Ammon OHE is a way of integrating lab tests and predicting the development of overt HE. And at stake here is this early detection, which allows us to initiate early therapy. And one such therapy, lactulose, which is the most studied in this context, if started for people with early HE, reduces the risk of dying by 44%, a hazard ratio of 0.56. So we're talking about the opportunity to save lives. So going deep on these two bedside tests, I like the animal naming test because I could do it over the phone. I simply ask a patient to tell me to name all of the unique animals that they know. I count them out. I don't let them double count horse. I'm excited if they tell me something new like capybara. But that number of animals that they're able to report to me is associated with a risk of encephalopathy. If the number is less than 10, that is a very high risk number. And then here is the Encephalap Stroop. Go ahead and download it. Go to Dr. Bajaj's website to interpret the numbers that this app will yield in terms of contextualizing the risk of covert encephalopathy. But these are just numbers. And there are a variety of reasons why someone's animals named might be low or their Stroop test might be low. So everything has to be brought back to the patient. So I would only apply these tests to people I think are at risk for developing encephalopathy. That is to say, people with cirrhosis and either a sick liver defined by an elevated bilirubin or low albumin count, or portal hypertension, shunting of blood away from the liver. And that I would pick up from the labs, like a low platelet count, or the presence of varices, varicose veins in the abdomen or the esophagus. These are the people who are at risk for encephalopathy. And the people who are the highest risk for having covert HE, they might give you a bad animal naming test or a bad Stroop result. But rather than just treating a number, I want to condition the decision to initiate a therapy based on something that is bothering the patient. This not only allows me to check back with them in 28, 56 days and ask, how are you doing? But I can have a very specific symptom. This is what's bothering them, and has it gotten better? Do I need to go back to the drawing board and rethink this diagnosis? And some of the key things are, 1, that the patient is experiencing falls. 2, that the patient reports a very high impact of their liver disease on their daily activities. Or 3, that they rate their sleep quality as poor. Of course, many things can cause each of these symptoms, and that's why time-limited trials are necessary to validate the initiation of an HE-directed therapy. It is interesting sometimes approaching this topic with clinicians, where I move away from talking about blood tests to talking about asking patients about these subtle symptoms about impact on daily activity or falls. But we did focus groups with patients across the country, and we asked them what was important for us to address. And of course, they told us that things like ascites and volume overload and overt encephalopathy were very important. But equally important to them were things like falls or depression, things that are probably or oftentimes driven by covert HE. So if we were to initiate a therapy such as lactulose in case control pre-post studies by Dr. Sarah Montagnesi, that lactulose improves sleep quality. In a recent randomized trial where I took people with portal hypertension and a high impact of cirrhosis on their daily activity, and I randomized them to lactulose or not, the people who took lactulose reported good sleep at a rate that far exceeded those who were in the control arm. Lactulose can improve sleep quality, and that informs most of what's impacting quality of life. So the problem is that lactulose, it will increase the number of times that you're pooping. And sometimes it can cause abdominal cramping. So you want to make sure that someone is going to benefit from it. But in this meta-analysis of randomized trials performed by myself and a colleague, Dr. Andrew Moon, we found that HE-directed therapies such as lactulose or rifaximin was associated with sustained, significant improvements in quality of life. The specific indices of quality of life are listed at the bottom. Don't worry too much about them. They're just numbers on a page, but the questions that are contained within them are asking about fundamental features of the human condition. Are you participating as an active member of your family? Are you working? Are you raking the leaves? It's not just a number. It's about activity and contributing to one's community. So if you're going to start lactulose, which is the cheapest, most available therapy directed towards HE, you don't want to scare people away, because like I said, it will cause excess bowel movements if you take too much. I was personally prescribed lactulose so that I could figure this out and empathize with my patients, and I learned a few tips and tricks that I'd like to share. Number 1, it's a syrup. Even though it's super sweet, it doesn't cause a high blood sugar because it's not absorbed by the blood, but it is very sweet. So if that's your thing, you can take it straight from the spoon. But I preferred to mix it in a drink. I would put it in water, and if you put it in cold water, it will taste like flat Sprite. But beware, it will fall to the bottom, so you got to beat it up so that it doesn't just sit at the bottom of the cup. I put it in coffee. It tasted like I sweetened it with Splenda, and I thought it was great. If you just want someone to find the right amount of lactulose, you start low and you go slow. 1 tablespoon, 10 grams of lactulose ought to do nothing, symptoms-wise or effectiveness. But just get it started. On day 1, a tablespoon. On day 2, a tablespoon twice a day. And then you start slowly adding extra tablespoons until you get to a place where somebody has had a change in their stool caliber so that it is now softer, and they're increasing their bowel habit by 1, maybe 2 per day. And they're doing it with control and without any diarrhea or increased urgency. The bedside test that I like to use is this impact on daily activity. And I just want to reinforce this because we studied this in a group of 300 people with portal hypertension who did not have hepatic encephalopathy, and then we followed them for a few years. And if they told us on a scale of 0 to 10 that my cirrhosis impacts my daily activity with a rate of greater than 2, certainly greater than 7, it was at very high risk of encephalopathy. If they said that it was a 10 out of 10, there was a 54% probability that they would develop encephalopathy at the end of the year. So you can do all kinds of fancy tests, or you can just listen to the patients. They're probably telling you that they're suffering from an early stage of encephalopathy on the basis of this question, which took me no more than 1 or 2 seconds to elicit. So this is that randomized trial that I was showing you about. I took people with cirrhosis and portal hypertension with moderate 4 out of 10 or greater activity impairment. I gave them lactulose twice daily, and I followed them for 28 days, which is a reasonable test of treatment for improvements in quality of life, the animal naming test, activity impairments, sleep quality, and falls. And lo and behold, what I found is that there was a trend towards improved health-related quality of life, but it's possible that 28 days is not enough because that was not statistically significant. However, by the end of 28 days, people were naming more than 3 animals on average. Their sleep quality was improved, and their activity impairment was significantly reduced. 28 days is enough to see if this intervention is working. And this study taught me a lot, right? I don't want to just send people out into the wild to figure things out on their own. I was actually using text messages to figure out if people were pooping too many times because I don't want them to run away from the trial, and I don't want them to get dehydrated. Now, you might not have text messages available to you in your practice or with your clinicians, but for research, I think this is a basic idea, and it can be supplemented with just following your bowel movements, knowing when to call the clinician, and maybe a 1 or 2 week check-in from the nurse after initiating lactulose therapy. There are tons of other associated symptoms that come along with encephalopathy, many of which are addressed by an actual HE-directed therapy. But our coping with these symptoms is equally important and ought not be ignored. So Dr. Bajaj, the guy who developed the EncephLab Stroop, he took people with HE and their caregivers, and he put them in meditation class. And what ended up happening after a few weeks of meditation class is that the patients and their caregivers reported better sleep quality and reduced depression. So I think we have to think holistically about not only the therapies that we're prescribing, but one's perception of their symptoms, and leveraging the mind-body continuum is a reasonable, increasingly mainstream idea. There's another opportunity for us to prevent the development of encephalopathy, and that is when we go ahead and do something high risk. So sometimes when people have variceal bleeding, a complication of portal hypertension, or the ascites abdominal fluid collection, we will elect to place a stent in their liver called a TIPS. And this TIPS will resolve the risk of bleeding and often resolves that ascites, which is wonderful, but it creates a highway for gut blood to go straight through the liver without being metabolized and affect the brain. So, can we prevent the development of encephalopathy because that blood is bypassing the liver, delivering toxins to the brain? This is a screenshot from a randomized trial where rifaximin was given prior to the TIPS, and it was associated with a significant reduction in the development of hepatic encephalopathy, which is fantastic. But if you read the fine print and you look at the appendix, what you'll learn is that some of the people in the study were stable on lactulose, and they were asked to stop that lactulose prior to initiating this randomized placebo-controlled trial. And those people were the ones who were most likely to develop HE. So what I take from this is that rifaximin will prevent HE. But if I could also try lactulose, and I certainly wouldn't stop lactulose prior to a TIPS, because my aim is to keep these people out of the hospital. So let's talk a little bit about the management of overt HE, because this is important to get across for a number of reasons, because the urgency is very high. We don't want people to get into trouble into the hospital. We want them to wake up very quickly and go home to be with their loved ones. The first principle of overt encephalopathy is you see somebody lethargic or obtunded, comatose, you think about lactulose immediately, but you have to think about why this patient has developed HE. What triggered it in the first place? Sometimes it's dehydration. Oftentimes it's dehydration. After all, many people with cirrhosis are being given diuretics. But it could also be GI bleeding. It could also be an infection. And it's not the HE that is fatal in these cases. It is the infection. And so it is critical that we see hepatic encephalopathy as a biomarker of badness and initiate a package of interventions and screening for infection that would define high quality care before we go to treat the encephalopathy with HE directed therapies. First line treatment for hepatic encephalopathy in the hospital is fluids. This might surprise you given all that I've been saying about lactulose and rifaximin, but remember that that patient is encephalopathic for a reason, and it was triggered perhaps by dehydration from diuretics, bleeding, or the effect that infection has on one's blood volume. And so giving people fluids by vein or by mouth is often enough to help them eliminate some of that ammonia. Many people will wake up with IV hydration alone. So IV hydration, first line treatment for encephalopathy, but it is not good enough in many cases. So we also have to think about how to dose lactulose. And remember about how gingerly I was treating lactulose in the outpatient setting because I didn't want to scare people away? That is not how I manage encephalopathy in the hospital. I use induction doses of lactulose, not that maintenance dose stuff that I worked people up to. I give people lactulose every couple of hours until they have a bowel movement or they wake up. And that is critical. After that, then you peel back to the maintenance dose that will help them stay out of the hospital. The last set of things that I'd like to talk about here is what to eat when you have hepatic encephalopathy, which is one of the first questions that patients will ask me. And there's some myths out there that might be limiting effective care for a lot of patients. The most important thing to know is that a patient with cirrhosis needs to have 1 gram per actual kilogram body weight per day. If you restrict protein in the diet, that's fewer amino acids in the gut. And momentarily, that might mean a lower ammonia level. But in the long run, it will create malnutrition and wasting. And in the context of cirrhosis and portal hypertension, skeletal muscle in your arms and your legs is actually what's taking up and metabolizing 50% of the circulating ammonia. And that process is catabolic. It's breaking down muscle. So failure to support your muscle is failure to support your system's auxiliary processes for eliminating ammonia. And that's why I prescribe 1 gram per kilogram protein every day. Does everybody know where protein comes from? No. So I will refer to a nutritionist, or I'll refer to a handout that we have prepared in clinic, or cirrhosiscare.ca. But while I'm faced with the patient, I'll go over what they ate in the last day and talk about ways that we can fold in more protein. And I will share some tips and tricks. I love Greek yogurt. I love peanut butter because it's cheap. I love eggs because it's cheap. I like to find ways to put milk into things. And so helping people understand how to enrich each of their meals with more protein is something that I can do successfully in a couple of minutes, and it is extremely important. The other thing about protein that cannot be ignored is the importance of overnight fasting. So when we're sleeping, we're fasting. Now, for people without cirrhosis, it's no big deal. After 3 days, your body will be so starved for extra sugar that you'll begin to break down your own muscle. But the patient with cirrhosis has a shrunken nodular liver. It cannot make as much sugar to feed the dreams and so forth that are powered by sugar overnight. So the brain of a patient with cirrhosis will send signals to say, I need more sugar. If the liver can't produce it, then the patient will begin to break down their own skeletal muscle to feed those processes. And over one night of fasting, a patient with cirrhosis will lose the same amount of body protein that would a patient without cirrhosis who fasted for 3 full days. We have level 1A evidence, randomized trials that support nighttime snacks. This is a study which showed that people who ate the same number of calories, but there were half the group that had a lot of their calories right before they went to bed, and as soon as they woke up in the form of Ensure Plus, were less likely to lose muscle mass, and they felt better and had less encephalopathy over time. So you don't need to buy Ensure Plus, although it's great. You could also think about peanut butter. You could think about cottage cheese, rice balls. Anything with at least 200 calories and a few grams of protein should suffice. There has to be something in the tank before someone goes to bed. The take-home messages from my component of this talk were to review the symptoms of encephalopathy, and they are more than just disorientation. They include falls, depression, and dependence. The benefits of treatment are multifold and include improved survival, reduced time in the hospital, and improved quality of life, which manifests as active participation in one's family and community. And the third point is that a patient with cirrhosis and hepatic encephalopathy needs to have a high protein diet overall, and especially with a snack before they go to bed. It has been a privilege to speak with you today. So on behalf of myself and Dr. Rose, I thank you for your attention.
Dr. Rose and Dr. Tapper, thank you so much for your unwavering support and dedication to increasing healthcare provider and patient education on hepatic encephalopathy. Your discussion on HE today is not only genuinely insightful, but incredibly necessary to have. And your commitment to shedding light on this topic is greatly appreciated. Thank you again. It is now my pleasure to introduce our next panel of doctors to today's discussion. Please meet and welcome Dr. Anjana Pillai, the Medical Director of the Multidisciplinary Liver Tumor Program and a Professor of Medicine at UChicago Medicine. And please also welcome Dr. Jennifer Guy, the Director of the Liver Cancer Program at California Pacific Medical Center. Doctors, a very warm welcome to both of you. We are really grateful to have you on today's discussion. And I'm also delighted to introduce Bruce Dimig. Bruce brings a wealth of experience and knowledge to us as an advocate and a patient, boasting over 10 years of dedicated work with both professional and medical organizations. Bruce is a Global Liver Institute A3 Advanced Advocacy Academy alum and a GLI ambassador. Bruce, thank you also for joining us today. Welcome, everyone. In preparation for our webinar today, I was really excited to engage with the patients and caregivers that we serve at GLI. And a big portion of this webinar wanted to further talk about communication strategies and education that you two as doctors, and Bruce, what you bring as a patient and an advocate, how that looks to help increase their benefits through healthcare and really how that communication plays a role. And part of that was wanting to hear directly from the patients and caregivers that we serve and help. So I'm excited to jump into some of the questions that were submitted by our patients for today. And the first question goes to both Dr. Guy and Dr. Pillai. The patient submitted the question saying, discussing liver disease and treatment plans with patients can be challenging, and we often feel overwhelmed by the amount of information that are provided to us from our healthcare providers. Liver disease is so complex. How do you properly tell us and educate us so we can be prepared? And what strategies do you use to effectively communicate about treatment options and diagnoses?
Well, I'll go ahead and get started. Thank you so much for the invitation to join you all here today. And it's really important to me that I get an opportunity to really help educate patients and their caregivers. It's such an important part of what Dr. Pillai and I do. And so thank you for everyone for submitting your questions. And the person who wrote the question is correct. Like, liver disease is extremely complicated. And I think that one of the things for all of us to remember is that because it is complicated, there's going to be a conversation ongoing over the course of someone's illness. And so oftentimes that first visit can be a lot of information, but I like to try to remind people that the disease and the illness and health is not static, and that it'll evolve over time as we get to develop a relationship over time. When I am communicating information, I also try to do it in different ways. I'm a big fan of visual learning, so I oftentimes draw a liver on a piece of paper and draw arrows where blood flow is going and why things might be developing because of how things have changed when someone has advanced chronic liver disease. And then also, I often write things down. This is what we talked about. Here are the diagnoses we gave. Here are your to-dos. Here are my to-dos. And then I think finally, at that first visit, trying to set some expectations from the patients as well as the providers about what is this going to look like as we start to understand your illness together.
I would echo many of what Dr. Guy just mentioned. I think we have very similar practice patterns, but I also agree, chronic liver disease is so complex and it evolves over time. So why you may see me in one setting will be very different than if you're seeing me in a liver transplant setting. So as Dr. Guy mentioned, I also am a big fan of follow-up visits early on after that first initial visit because there is so much information. I agree with the visual guides and writing things down. We do encourage all our patients to bring at least one other person, which was, very hard during the times of the pandemic, but it also allowed us to open up Zoom. And even if relatives or friends can't come to the appointment in person, I encourage someone to just maybe have someone else on the phone just to have another voice to hear. I think that's really important. And then we also have educational materials that are printed out that we have them take home. And sometimes that even can be a lot, right? There's like a whole binder and who's going to read it. So I will tell them, look at it when you can. And a lot of it's just highlighting the things that we did. And I think an important aspect of this is establishing trust in the system. So where I am at University of Chicago, we really serve a wide array of patients and patient education and socioeconomic levels. So that initial trust does take some time with certain patients just because they may have had bad experience in the past, or they're just a little nervous about, the idea of a transplant, or is it experimental, those kind of things. So I think just taking some extra time to establish that trust and then diving into the liver disease process, as Dr. Guy mentioned, is really key to enabling a long-term relationship.
Thank you. That's really helpful. I think the complexity of the liver as an organ is what really makes the liver disease more challenging, especially on a multidisciplinary side. Having a primary hepatologist to be able to go to and really setting that trust and foundation from the beginning certainly makes a difference. And like you said, encouraging to make sure that at least one other caregiver at a minimum is there to help process and hear information in a different way and keep track of that. So thank you. The next question that we have kind of segues off of what we were just talking about, but this patient asks, in emphasizing the significance of really educating patients on their diagnosis and treatment, we acknowledge the importance of building trust and facilitating effective follow-up communication. So reflecting on your experiences, and Bruce, also your experience as a patient, can you elaborate on that crucial role of establishing rapport? And then also, how does that play and have space in diagnosing secondary effects of liver disease? And what do those factors contribute to early detection and management of those conditions, so it's not too long into the process after a patient is experiencing that before it's talked about?
I can start with this one. I think that's such an important question, that aspect of trust and long-term established care. I mean, you can be the smartest person and know all the plans, but if you can't, really maintain that patient provider relationship, then they may not come back, and you lose an opportunity to really help someone. So I think, as we mentioned earlier, just taking that time, especially in that first visit, because I think both of us see patients at many educational levels, I really early on try to figure out where I am at with the patient, what they know. Some people already have family members that have gone through this process, or friends, and they know more. Others, this is their first time even entering the healthcare system in a significant manner, so it takes a little bit longer. And as Dr. Guy said, visual aids really help in understanding. And once I feel like a patient feels that you are invested and we have that rapport, then it's a lot easier. And then following up. So I try not to overwhelm everything on that first visit, but we talk about, these are the expectations in visit 2 and 3. These are the possible outcomes of advanced liver disease and why you're here. And these are potential preventive things we can do, whether it's surveillance or whether it's nutrition, exercise, to prevent things from getting worse. So I try to kind of parcel it in a way that it's not overwhelming, but they also have expectations. And I think that initial visit really sets the tone. And for some people, if you don't hit it off right away, I always tell my trainees, it's really not the patient's fault. It's really on us to kind of understand where they're coming from, because many of the times it's really fear driven, right?
Mm-hmm.
If people sound closed off, or if they feel like they can't really connect with you, it's really a mistrust or fear more than they're really being, obnoxious or mean, per se.
Bruce, what has your experience been with this, and especially being able to understand kind of the secondary effects, but also building trust and rapport with your providers?
Yeah, I would agree with Dr. Pillai that the building of the trust is very important in connecting with the doctor. I have a couple of doctors that I've been with for 10 years, and the biggest, there's like a few big points that I'd like to make. Sorry, my HE. One is to be open and honest with the patient. Don't sugarcoat it. The patient deserves and needs to know what's going on. They're only going to be able to determine their course, how they want to handle things, if they have the information to do that with. And I think one of the biggest things is, again, no disrespect to the doctors, but listen to the patient. Listen to what, if they're saying their body feels this way, understand it, and process it, and try to help them understand why their body is feeling that way. Or gee, it could be this, they're having this symptom, well, gee, maybe it's this. And another point would be, talk to the patient, not down to them. Again, that kind of goes back to the open and honest thing, because I've run into that in the past. And to me, one of the biggest things that I've learned over the years is familiarize the patient with the patient portal.
Mm-hmm.
And put your clinic notes in the portal. I can't tell you how many times that's been so important to me, is go and have the patient read the clinic notes so they can understand where where the doctor is coming from. Because those little visit summaries that they give you are worthless to the patient. Seriously, they mean nothing. Read the clinic notes.
The clinic notes, I mean, that is such a good point in the modern day with digital healthcare. What does that look like? And I do think, Bruce, you talk about a gap that we look at from a health literacy side. Access, what does that look like for patients and caregivers where there are disparities, health equity issues that maybe don't allow them to connecting on that way? But then equally, what is the responsibility for all of us as healthcare providers and part of institutions taking care of patients to make sure that they really do understand in their doctor's terminology, and then also on the patient's own side with their familiarity. So thank you for saying that. I think that's just an excellent reminder for all of us.
I was just going to say, I think another thing about building trust and listening is that it's not just the doctor and the patient and caregiver in the room. It's a whole system of people who are helping to care for patients. I rely on my social workers and my nurses and my schedulers. And without them, we wouldn't all be able to provide the best care. And so I think that that's another piece to remember, is that we're all a team. And so sometimes that works where you have trust in everyone, and sometimes the system breaks down. And I think having a backup plan for when the system isn't working, to what the goal is to meet the needs of the patient and the caregivers. I think that builds trust. And so what we do here is, we give, I have access to all of my patient messages, so I'm responding to my patient messages, but then also we have phone numbers for all the different team members who might be able to translate doctor speak into something else if that's what's needed, or get the appointment for the biopsy if that's what's needed. So I think that is also another piece of things. I always leave the visits telling the patients that I'm hopeful that they're going to be their best advocate. And if the system isn't working well for them, they need to let people know, so that then we can all try to get back on the same page, because that's how the trust really at the end of the day is going to be built.
I was just actually going to say the exact thing about the patient advocacy, being your own advocate, because I think Bruce brings up such great points. We all have the best intentions, and sometimes these systems can break down. So yeah, I say the same thing, don't wait for our next appointment. If something is not happening the way that you anticipated or you were told by me inadvertently, please call, please message. And to your point of, we also have, all, like you said, patients, all different backgrounds and needs and financial resources. If they cannot get to a MyChart or, where they can see everything, our nurses know who those patients are, because we do ask that. And then it's more follow-up communication via telephone, more, more of the standard, what we always used to do. But I think that is really important, not to assume that everyone has a smartphone or has the ability. The only thing I will note is with access to medical records and patient clinic notes, is I do have a disclaimer in mind that this is a medical document. So sometimes you may read things and feel like, wow, like I'm just a 47-year-old man, or something like that. And, and so I have a disclaimer. This is a medical document, and it's written as medical speak, just so that they understand this is not anything personal one way or the other towards them when we talk very objectively about them and their disease process and their plans.
One thing that I'd like to add, and knowing that doctors are very busy, it's you have a lot of stuff to do. The one thing I've also learned is, from the patient side, is get to know your doctor's MA. They are like to me, that's the cog that makes the whole thing work. Because if I can't get a hold of the doctor, I can generally get a hold of my hepatologist's MA. And she is it could be a he too, but they are the link between the patient and the doctor. And if you can have that rapport too with the MA, and the doctor has the trust of the MA and the patient has the trust of the MA, you can have more of a seamless connection there. And, if you have a question, go to the MA if you can't get a hold of the doctor, and, they can usually take care of it for you.
I think that patient advocacy piece is so important, and Bruce, you do that really, really well. That's an area that we try to educate patients, making sure that they know they have the ability to use their voice to make change and get follow-up. And oftentimes we will do HCP or multidisciplinary training and remind the doctors to encourage the patients to ask questions and push back, and don't take it as kind of that word of God philosophy on just because I said this does not mean that you can't push back or question or ask for a different opinion. And that's a hard thing to learn too, if that's not an instinctive trait to be an advocate. I'm also curious, Dr. Rose and Dr. Tapper had talked a lot about focusing on HE and what hepatic encephalopathy looks like. How do you, Dr. Guy, and you, Dr. Pillai, at what point do you bring up if a patient doesn't present signs or symptoms of portal hypertension or ascites or HE? What does that look like with the complexity of so many other functions with your liver happening and so many multidisciplinary team members on the patient's case simultaneously? At what point do you bring that up? Is it standard on second or third appointment, we're going to start talking about this? Is a little bit of wait for the patient or caregiver to present with some questions?
I think it's a little bit what Bruce was saying, which is the patients need to understand what their illness is like so they can make decisions, they can plan for the future, and also they can alleviate anxiety or uncertainty that might come up when they're trying to look ahead and trying to understand what their diagnoses mean. So when I meet someone for the first time with cirrhosis, we go through what their symptoms are, but then I also, I do my little diagram and I explain, like, this is where you're at right now. Your liver is functioning fine, but here are some things that we want to be paying attention to for the future. And that's when I start to discuss what is portal hypertension, which for those who may not be familiar with that term, the idea of portal hypertension is when there's increased pressure at the level of the liver, which causes some backup of blood flow, resulting in some symptoms, for example, like ascites or some rerouting of blood flow to develop things like varices in the esophagus. And with that rerouting of blood flow, you can have a shunting of some of the toxins that the body makes, and the liver is normally filtering that. And when it's not going through the liver to get filtered, it sort of reroutes and can go to the brain. And one of those toxins is called ammonia, and it can cause hepatic encephalopathy. So I use my visit, depending on sort of how severe people's symptoms are. We might just start with, you're presenting with hepatic encephalopathy today. This is why you have it. We'll talk about the next sort of things at another visit. Or if they come and they have stable cirrhosis, but they want to know what this means, and we kind of go through, what the symptoms are and what their liver is able to do today, and hopefully what it'll do tomorrow and into the future, as long as we can stabilize the liver disease. So there's so much nuance in all of this, and I think that's where we also get back to what Bruce is saying, is to listen to the patients. And like what Dr. Pillai said, she asks, what do you understand and what are your goals? I always start with my patients' goals for each visit, because obviously I have goals, I have a checklist, I have all the things that I want to cover, but I really want to know what do the patients want to cover first, and then we'll kind of get to the rest of the stuff as we can. But again, it is an evolving conversation over time.
And one thing I'd like to add, that was so perfect, is just that repetition is kind of key here. Because sometimes when on return visits, you'll feel like, oh, I feel like that last visit went really well. I feel like we nailed it all down. And then sometimes they'll be like, do I have cirrhosis? And you're kind of back to the beginning. And so I think that's important to validate that and say, yes, maybe you don't remember some of it, or maybe it was really overwhelming. Let's go over this again. And yes, this is what you have. And sometimes I do really have a few patients that ask me every single time, what their diagnosis is, just to kind of, I think, just reassure or assure themselves that we're looking at the right thing and this is what we're moving forward. And also when, for our long-term patients that are kind of every 6 months, that are not in the throes of transplant, it becomes so routine. Sometimes you forget, okay, I'm getting an ultrasound, and why are you getting an ultrasound? We're looking for liver cancer. maybe you forgot that, but we talked about that a lot in the early years, but maybe not now 3-4 years down the line. So I do try to remind them, this is why we get the blood work, this is why we get the endoscopy, this is why we're getting the ultrasound, just so that those reminders are still there.
Those are really great. Thank you, everyone. Our third question is, when navigating the complexities of liver disease and its complications, it's challenging not only for healthcare providers, but also patients and their caregivers. So speaking more about portal hypertension as being a serious complication of liver disease, can you explain, Dr. Guy, I know you just talked about that a little bit right now. Could you explain a little bit more about what portal hypertension entails, how liver disease occurs, leads to this occurrence in patients, but what can we do then to reduce the progression into ascites? Are there ways that we can hopefully prevent or slow down some of these, and suggestions that you might give to patients and caregivers?
Sure. So I think the first thing to remember, especially because this audience is probably coming to this webinar with lots of different backgrounds and maybe also just different stages of liver disease, is that liver disease is indeed a spectrum. And so when we're talking about complications of liver disease, usually that's happening in the setting of cirrhosis, where the whole liver is scarred. And when the whole liver is scarred, then the question is, well, clinically, what does that mean? Is the liver able to do its jobs, or is it not? And so early cirrhosis, we call it, the liver is able to do its jobs fine. So maybe people don't have symptoms. We're still surveying them for complications, like, for example, liver cancer, and we're monitoring to see if they're at risk for developing things like portal hypertension. But once portal hypertension develops, what that means is the liver is having a harder time doing its jobs. I had mentioned this problem with increased pressure through the liver as the liver gets scarred down. And then after that, once there are elevated pressures, and there are different ways for physicians to assess this. One of the common ways is with transient elastography, physical exam, imaging, history. But ultimately, when someone is diagnosed with portal hypertension, we usually think of that patient as being someone who has more potential for problems with their liver disease. And so we're having a lot more of a discussion monitoring situation. There are ways to prevent going from a place of cirrhosis to a place of having portal hypertension. And really one of the main things is really understanding what is the initial cause of the liver disease, and then how do we sort of manage that problem. For example, if it's hepatitis B, we put people on treatment. If it's hepatitis C, we can put people on treatment. If it's autoimmune liver disease, we can put people on treatment. If people have problems with alcohol, we recommend complete abstinence from alcohol. If people have problems with metabolic associated liver disease, then we really focus on diet, weight loss, and managing some of the complications of problems of diabetes, hypertension, high cholesterol. So there's a lot of different things we can do to treat someone when they're at early cirrhosis, hopefully even before they get to the point of cirrhosis. But if they get to the point of cirrhosis, what we can do to try to prevent them from having a complication of portal hypertension. And then finally, if they do have portal hypertension, then there are other medications we can use to try to prevent worsening. There's a lot of information and discussion that you should be having with your primary hepatologist around a medicine called carvedilol. And then if someone has, for example, ascites, which is when the belly is full of fluid, then really important is a good low salt, high protein diet. That's like fundamental to managing ascites. And then we have some medications we could give as well. And then ultimately there are various procedures we could talk about, but I don't want to go in too deep. We're already pretty deep there into cirrhosis and decompensation. But the idea is, this is why you have a liver team. And I think that's the other piece here, is that viewers might be trying to figure out, well, like, who's on my medical team, and do I have the right people on my medical team? And if you have access to being able to be seen by a liver doctor, even if it's maybe your local doctors because you live a far away that are going to help manage these things, it's really nice to understand what the landscape is and make sure everybody's on the same page. So that's why if you can see a gastroenterologist, a hepatologist, it's a great idea to get this education.
Thank you.
I wholeheartedly agree with all of that.
I was going to say, I feel like we often hear from patients, obviously the easiest thing would be for one magic answer that they ask, like, what should I be eating? What shouldn't I be eating? What does exercise look like? And to one person, moderate exercise means one thing and to another. And so we oftentimes say it's so subjective. And it goes back to that first question when we're talking about establishing rapport and trust, not only from the patient to the provider to the patient, because it is unique to every patient. There's not one answer. Dr. Guy, as you mentioned, like if we have to abstain from alcohol, that is individual to your case. A low sodium diet might be individual to you. What does a high protein diet look like? How do we modify exercise or movement or mindfulness practices? Those are areas at GLI that we will continue, especially on the liver cancers department side, on making sure that we can explore into options, but really with that understanding of the patient, being able to have those conversations and question that with their entire provider team. So thank you. And certainly throughout the rest of the conversation, if you have other tips relating to management and various healthcare members, but really looking at symptom management and what they can do, please let us know. Bruce, though, at this time, I want to welcome you back in. I'm really happy that you've been part of the conversation so far, but not only was it important to us to highlight some questions that the patients and caregivers that we serve have asked, but really to have you lead some conversations that are specific to your patient experiences, and also from the stories that you've heard through your 10 plus years of advocacy work and being a patient and being in the waiting room with others and working with a lot of doctors during your life. So I'd love to hand the microphone over to you and have you facilitate the next few questions.
Well, I guess the most important thing would be to let you know what my current status is. I now technically have 3 different liver diseases. I have MASH, which for everybody is the metabolic associated steatohepatitis. I also have a fairly rare liver disease called nodular regenerative hyperplasia. And then the last one that I was just diagnosed with is genetic hemochromatosis. So that's kind of where I'm at right now. But going back, I started my journey 12 years ago. And I've been dealing with it ever since. Like was said, to have a care team, like I said, I've been with some of my doctors for over 12 years now. And that's critically important for continuity of care, which is another thing which needs to be pointed out, is that in order to have that rapport and that trust with the doctor, it really helps to have the same doctor for multiple years, or at least in my case with my hepatologists that have come and gone, I've been in the same clinic. That's really important. And as kind of has been elaborated on or touched on, I have I don't have ascites, I don't have jaundice, but I do have esophageal varices. I do have splenomegaly, and I have very severe portal hypertension. So yes, I from that I developed HE, and as was mentioned earlier, mine is constant. And we kind of think that that's possibly due to my NRH, because some of my central veins in my liver lobules are missing. They're not there, which may be causing, as Dr. Guy said, creating that back pressure in the liver, causing my HE. So again, today I apologize. Sometimes my HE makes it hard to talk. But I think one of the biggest things that I tell other patients is eat as healthy as you can, exercise as much as you can, obviously stay away from alcohol and try to keep as positive an attitude as you can. And I will admit, there are days that I have pity parties. And I think doctors need to realize that too, and patients need to realize that most people are going to have those. You're going to have days where it's like, oh, woe is me. But try to keep as positive an attitude as you can. Do you want me to get into the questions that we have there, Sarah?
I would love that. And Bruce, thank you for sharing that story just so our audience today understands a little bit more. And I think that the suggestions that you gave are so helpful and beneficial, and oftentimes can be that light bulb that another patient or caregiver needs to hear from someone that has a similar lived experience.
Real quick before the questions, it'd be one of the other things was kind of touched on is the patients, please, if you're going to an appointment, write your questions down. Try, take the time and write the questions that you want to ask, because especially if you have HE, you may not remember at the appointment to ask the questions. So write them down, and make sure you write the answers down. If you can't do it your own, if you have a caregiver, have them record the answers to the questions. So then you have your own record of what was discussed.
Thank you.
I'm sorry if I may, but you want me to read the question directly, or?
Yes, please. That would be great.
For one of the questions that I would have would be, while hepatic encephalopathy may be one result of decompensation, there are other symptoms that can also define decompensation, such as ascites and or jaundice. Can you elaborate on what defines decompensation?
Sure, I can take this one. I think we talked about many of them. I think the obvious or more ones that you see because you see it physically happening to you are the jaundice, the yellowing of the skin, or the eyes, the ascites we talked about, or fluid in the lungs, which is called hepatic hydrothorax. And then, the varices, which Bruce, you said you have varices. So sometimes know that you have it because you underwent routine surveillance. Other times you find out the hard way because you had a big bleed, and that's how unfortunately, is your first kind of diagnosis of liver disease. A liver cancer, with both Dr. Guy and I are, very invested in, is another common complication that can happen, especially as your liver disease progresses, and you may just feel fine, and that could be the first decompensating event that you have. But things that might be less really overt, and of course encephalopathy, as we discussed, but things that may be less overt could be this this progressive weight loss or weakness. So we call it sarcopenia or frailty. And so that, or coagulopathy, Bruce said that he has a big spleen. Most often that's, also associated with lower platelets. And as portal hypertension progresses, you'll also see that your INR, one of the measures of your clot, how well your blood clot, starts getting worse. So there are these markers of your synthetic liver function that can get worse. And that's why we routinely do get labs every 3 or 6 months, even if you're asymptomatic, to make sure that we're watching this progress. So the overt things you can easily see. So any of those things really, so if you're, when we look at liver function and liver markers and how well you're doing, can look at someone and say, okay, this person looks very compensated. They don't have any of those things physically. But then you can look at the blood work and say, you know what, your Charles-Pugh function or your MELD score, and those are kind of markers that we use of assessing liver function, has really kind of gone up. And even though you don't have ascites that you can see, or maybe you don't have overt hepatic encephalopathy, but you've noticed some mild changes in cognition, or your partner or whoever lives with you noticed that, or we notice that your platelets are worse and your INR is up, or your albumin is really kind of been trending down over the last year. Those are things that I still, those are still potential areas where your liver is decompensating. So understanding that and just having discussions with your doctors about that. And I do like to be, again, with the overt things, it's easier for us to address. This is how you treat those. But even with the sarcopenia and the frailty, I think being a little bit more granular about protein targets and calorie targets, I try to do that. If you're pretty compensated, I tell patients, you need about 1 to 1.5 grams of protein per kilogram a day, or 25 to 35 kilocalories per kilogram a day. And that's kind of harder for patients because what does that mean? How do I get all that protein in? So, so like viable answers, protein shakes. These are a few. This is how much most have. If you have diabetes, making sure you're not taking one that's very rich in, glucose. And if you're decompensated, you have to really increase that protein amount, right? So now maybe you need more like 2 grams per kilograms a day. And you need more, meals very often, and maybe some late snacks. So I think it's really important in those kind of situations just to be a little bit more granular about the what nutrition means or what exercise means. And to Bruce's point, I try to say, if I notice someone's compensated, hey, you actually could work out 3 to 5 days a week, ideally 7, but no one does. But, in 20 to 30 minutes, 2 days of maybe some weights, 3 days of just some aerobic activity, walking in place, watching your favorite show for 30 minutes, So just giving people something that they can actually enact versus just giving a kind of overarching themes. I've always found that to be pretty helpful.
Thank you.
No, another question that I had was, as my personal case, I have constant HE. So not all cases of hepatic encephalopathy are episodic. So how would you diagnose that, and how do you differentiate constant hepatic encephalopathy from other causalities?
I think it's really where the art of medicine comes in when we're talking about different levels of confusion and where this is coming from. And I think hepatic encephalopathy can get challenging. And I think, Bruce, you bring up the important point. Like, first is, okay, well, what are all the possibilities? One could be, this idea of overt hepatic encephalopathy. We use this word overt, meaning it's like, you can tell, it's obvious, someone is like putting their car keys in the refrigerator and, is sleeping all day and really hard to get around people to get them to wake up. So there's like a whole spectrum of hepatic encephalopathy when it's overt. And then there's a whole area of research and clinical development around what sounds like, Bruce, you're experiencing, which is sort of more of this sort of occult hepatic encephalopathy that's there all the time. And distinguishing that from other causes too is important, because we want to be able to treat everything. And one thing to say is that we go through a list of, okay, well, what are people's nutritional levels? Like, could there be a vitamin deficiency? Is there anything going on at the level of a head CT scan or MRI to suggest a neurologic contributor? What about someone's mood? Do they have depression or anxiety? So we're going through all of these things to say, what could be causing the symptoms in each individual? And then from there, understanding, well, what are the different trials that we could use in terms of medicines or other behavioral things? I think one of the things to say about hepatic encephalopathy is, I'll be like, I sometimes go out to where my car is parked and I can't remember where it was because I wasn't paying attention when I came into the hospital in the morning, So I think it's one of those things where I say they're predictable patterns that caregivers are oftentimes recognizing before the patient. And so I think that it can be really hard to get our hands around someone when they have hepatic encephalopathy, and then how do we manage it? And there are strategies around management with medications once we have a better sense of diagnosis. I will say that a lot of people say, well, why can't you just send a blood level, like send the ammonia and give me the diagnosis and then we're done? And I explain that unfortunately the ammonia test in the blood is not an excellent test. Sometimes it's left in the tube too long. There can be just variability in the test. And so really hepatic encephalopathy is a clinical diagnosis when we're working with the patient and their caregivers to understand sort of, what their symptoms are, and then how do we improve it. The caveat, just because there's always a caveat, there's always like an exception to the rule, is that, we can use ammonia in the inpatient setting when someone is really sick and is not waking up. That can be helpful. So we use it more when someone's hospitalized, but we rarely use it in the clinic.
Well, I just want to add one of my favorite quotes that I remember reading, and I don't remember reading where, but it was also in a presentation I recently gave, and it's just to really what Dr. Guy just said about blood ammonia, because patients often ask about it because their other providers have used it. But the quote I like is, blood ammonia levels cause as much confusion in those requesting the measurements as in the patients in whom they're being measured. And it always kind of made me laugh because it's so true, because if you're talking to me and, you're asking me all these pertinent questions and ask me what your ammonia is, I often say, it's okay, it doesn't matter, because I know you're not encephalopathic. And then just to Bruce's, point, I do have patients like you who really have never felt quite right since their diagnosis. And, I think just to validate that is really important because, when you look at you, right? You're a level 3 advocate. You're here, asking all the right questions, but in your mind, you're like, this is not Bruce pre-diagnosis, right? And we wouldn't know this because we see you now and we're like, wow, you look fantastic, and I think just even validating that. And last thing, a medication review. I always do a full medication review every time just to make sure that even medications that, not just the big benzos and narcotics, but maybe some of the other medications can also cause or worsen existing encephalopathy, and I think that's important as well.
Dr. Pillai, you just brought up something that I need to mention for patients. Because everybody always asks, have a list of your medications and supplements.
Mm-hmm.
Not just the medications, that you get by prescription, but any supplements, vitamins, anything that you take, because everything has an interaction, and there's some supplements that are good and some that are not. But Dr. Guy and Dr. Pillai, you both kind of touched on something, medications for HE. Now, there's rifaximin, or for patients better known as Xifaxan, and there's lactulose. Now, I know a lot of patients kind of wonder, can either of those help prevent HE? If so, how? And can you just take one, the other, both? How do you determine what medication the patient gets?
Well, a lot of what we do as physicians is something called evidence-based medicine. So we're taking the studies that then go into guidelines and then putting it into clinical practice. But we always know, too, that like seeing a patient in front of us, things may change. But in terms of the evidence-based recommendations for treatment of hepatic encephalopathy, the first is to use lactulose, which was, discovered first. And a lot of patients have a lot of opinions on lactulose because it's a syrupy, solution you have to drink. And then the way it works is it acidifies the stool such that it pulls ammonia out of the bloodstream, and then you poop out the ammonia. So like my joke is like, not all bowel movements are created equal, because you need to be able to have bowel movements with lactulose to actually get rid of the ammonia. And so that's the first thing that we've used for a very long time. Rifaximin was like the new kid on the block. I think around about like 2008, one of my mentors, Nathan Bass, was the one that did the study, was, in this, special journal called the New England Journal of Medicine. And what it showed was that in addition to lactulose, rifaximin helped to prevent recurrent episodes of hepatic encephalopathy and hospitalizations. So this gets to your question, does it really prevent hepatic encephalopathy? Well, no, it treats hepatic encephalopathy with the goal to prevent the complications. So that's why, in theory, we're supposed to add rifaximin onto lactulose. In practical reality, I have many patients, unfortunately, who do not tolerate lactulose, in which case they are on rifaximin alone, and they seem to also do very well. But in those acute throes of an hepatic encephalopathy where someone's in the hospital, very, very confused, lactulose is really the mainstay of trying to get the ammonia out so that we can get to a better place, wake up the patient, and decide what the therapy going forward as an outpatient will be.
Thank you. good explanation for a patient.
Dr. Pillai, anything to add to that question?
No, I think that's right. The only thing with rifaximin, which, I think we both would use as much as we could, is just a cost issue sometimes because it is not generic, so it can be quite expensive. But, if I could ideally use that in someone, as Dr. Guy said, had it, and then to prevent rather than lactulose, I would. But sometimes you just can't. Most of the time you can get around it. This is why I bring this up. Most of the time you can get around it and you can do an appeals process because you were intolerant to lactulose or it didn't work for you. So it is important not to give up just because it was denied, and just to really talk to your healthcare team about how you could potentially use it, because it is a good medication. And with lactulose, it actually does really help. And the only other thing I've used is when, because lactulose can be, exactly as Dr. Guy said, just doesn't taste that great, causes a lot of distension, just gas. I substitute Miralax in there as well. And so that you still gets you your bowel movements, and the combination, this is not trial-based data, of course, here, but, with the rifaximin, the Miralax, and just maybe occasional lactulose can also work.
Just so you know, Dr. Pillai, when I wasn't getting enough bowel movements with my lactulose, doctor said, well, let's add some Miralax in.
Yeah.
But if I may, two points. One, just so as you doctors may know, but Bausch, who is the overall manufacturer of the Xifaxan, they do have a patient assistance program. Mm-hmm. So if the patient, if your patients run into a situation, please let them know. Mm-hmm. that there is, because now in my clinic that I go to, they have a specialty pharmacy that works with them, and they actually help the patient with the application process. And if you do qualify, you can actually get it for free.
I think that's true, Bruce, of many of our centers. That's a really, really good point to apply for that, and oftentimes you can. Thank you.
It's you have to apply every year, but mm-hmm. One other thing, because I run into this multiple times. In order to try to control my HE from getting worse, in addition to lactulose and Xifaxan, I also take sodium benzoate. So the question would be is, I'm sure you're going to be, you have and will get questions. Well, what about this? What about this treatment? What about this treatment? How would you address that with the patient and direct them to ones that actually may work?
I think the sodium benzoate question is interesting. We have certainly, I'm sure both of us have used it, and in the short term, it can work. There's no real great long-term data on it that I'm aware of. And it has to be compounded a specific way, and not all pharmacies have it, so there are some nuances to it. But I think what you said is really trying to get an idea of what has been tried, eliminating all the potential risk factors to exacerbate the HE, and making sure all that is properly done before we start adding, additional zinc is another supplement that you can add, or sodium benzoate and things like that. It's just kind of first making sure that you started doing all the initial things properly.
Thank you. Bruce, I feel like the three questions that you added to this conversation are so powerful. This discussion certainly wouldn't have been the same without you and having your voice and hearing your questions and experiences. So thank you. This is something that we want to continue to replicate, to bring patient questions, use their voices, raise their voices to make sure that they are heard. And I think that it can really help complete that robust care and understanding for everyone involved. Dr. Pillai and Dr. Guy, our profuse thanks to both of you for joining us today and bringing your expertise and your excellent communication and bedside manner. You are truly mentors to many, as we know, and I hope that a lot of people come away learning things from you, and we're very thankful, and Bruce, truly so thankful. We want to express our thanks to Dr. Rose and Tapper, who started this conversation today. It's just been fabulous all around. We appreciate your generosity and support. The commitment that you show to our liver community while advancing liver health and serving as pioneers with research and patient care is very admirable. Thank you to everyone who has joined us today on liver cancer care, management of hepatic encephalopathy, portal hypertension, and ascites. We hope you continue to join us for upcoming webinars and programs that we do. And for more information about GLI, please visit us at www.globalliver.org or visit www.livercentral.org, our hub for liver cancer research and resources. Thank you, everyone. Have a really great day.
Thank you.
Thank you.